So I'm privileged and delighted to be here and participate in this conference. I'm grateful to Champalimaud Foundation for extensive hospitality, and particularly to Andre, who was standing with the computer ready for me as I drove in because I had nothing to work and get my slides back to life. So just with a brief introduction, we start. So the topic that I will be reviewing is the complications of current oncologic treatments. And before we go there, I heard this in one of the conferences a few years ago, that there's only one thing more dangerous than an aggressive tumor, and that's an aggressive oncologist. And while we talk about new therapies, experimental therapies, like you heard in the previous talk, I tell the patients, and the way I think about it, is that the benefit may be questionable, but toxicity is definite. So you really want to focus on what toxicity profile you have, or drugs have, because they're already known before they enter into phase 2 trial. And then you decide which is acceptable and what's not acceptable. So therefore, complications are becoming more important and more relevant as we treat or manage our patients. So let's review them together. I'm from Cleveland. Cleveland is a small city between New York and Chicago. And so oncologic therapies, of course, range from surgery to radiation to chemotherapy and more targeted therapies. You heard some of them yesterday, and you'll hear more later today. So most of my talk will be on the targeted therapies. But let's not forget the traditional treatment and say what the side effects are and why we're moving away from them. So in radiation therapy, we know that you can have side effects, particularly on the eyelids, orbits, anterior segment, and of course we know about second malignant neoplasms, particularly in the realm of retinoblastoma. And they can be delayed, so that the complications are not necessarily up there, may happen many years later, and therefore may not be recognized or may not be discussed in detail. So those are the issues with radiation, and let's look into some of the common things that we see immediately after radiation. You see dermatitis, you see keratitis, you see conjunctivitis, but that's usually transient and usually will go away with topical steroids, etc., and supportive care, but not a big deal in generally speaking. But one thing I do want to emphasize is that the significant toxicity of radiation is actually dose dependent. And when you say dose dependent, pretty much nothing much happens below 40 gray. So if you are going above 40 gray, that's when you start to get retinopathy and optic neuropathy. So people are trying to reduce the dosage to avoid radiation retinopathy and optic neuropathy, but it's not that anyone who gets radiation will get toxicity. Below 25, pretty much it's very safe, except maybe cataract. So keep that in mind. That's all dose dependent, and in some scenarios, the dose may be so low that it's not an issue. Then the radiation retinopathy, it's just like diabetic retinopathy in its clinical manifestations, the difference being it's untreatable. So people are trying anti-VEGF agents, steroids, etc., but overall we know that we don't have a sustained effective therapy. So I would say at present, radiation retinopathy is really untreatable, and the only way to deal with it is try to avoid it. Optic neuropathy, very similar. Again, it's untreatable. People try steroids, but generally nothing really works. So, and of course, you have severe neovascular glaucoma, and the ways to avoid, which way do I point out? The ways to avoid is dose reduction, fractionation, and better ways of aiming the radiation with 3D, IMRT. Of course, we use brachytherapy and try to use different particles which can be focused better, such as protons. And as you can see here between the arrows, you can define the dose at a particular depth and sparing the other tissues. So that's the advantage with proton, and that's available in certain parts of the world. Let's talk a little bit about chemotherapy, and then how is targeted therapy different from chemotherapy. So that's how the toxicity profile starts to show up in a different way. So chemotherapy is non-selective. It affects anywhere in the cell cycle. And of course, it affects malignant and normal cells. So we are kind of familiar with this. It's nothing new in this particular thing here. You see hemorrhages. You can see infections like here. And you can see some other delayed effects like leukemias, etc., which can also be delayed and can be very serious and can be lethal. So although we don't talk so much about second malignant neoplasms, we hear about radiation, but chemotherapy has certain agents particularly are also at the same risk. So let's move on to the main topic, and that's targeted therapies. And targeted therapies, by definition, are specifically designed drugs that work on specific cell pathways. And for each cancer or each kind of malignancy, there is a certain kind of drugs, and they're kind of relatively new. I think for about 15 years, last 15 years, the first one was Gleevec. And they're emerging every year, every few months, there is a new class of drugs. So that's a challenge to keep up with them, particularly the names are very difficult to pronounce. Also, it's kind of hard to know how to even spell them or speak about them. So in any case, each cancer has its own pathway, and we heard about mutations and things like that. And at the moment you show a chart like this to ophthalmologists, everybody just shuts off. And I tried to make sense out of this, and I said, I'm not going to show a chart like this again in my talk. So let's look at something more basic. Okay, so what's happening in cancers is this. So cancer, this is a very important landmark paper. It's a few years old, but for ophthalmologists who try to understand cancer, I think this is very, very important. So what are the 4 or 5 things that the cancer cell is trying to do? It's trying to sustain the growth signals. It's trying to evade growth suppressors. It's activating mechanisms of metastasis. It's trying to become immortal. It induces angiogenesis and resists cell death. So all these pathways convert to this kind of survival advantage. And of course, one more, it tries to avoid immune destruction. And you heard a beautiful talk earlier today. So if you put all these things, that's the kind of things that are happening in the cancer cell. And so you have drugs for each aspect of it, basically. So here you have drugs that are inhibiting the growth. Here you have drugs that are stopping the angiogenesis. Here you have drugs, we don't see much in ophthalmology, PARP inhibitors. And then you have one more, of course, here, which are your inhibitors of checkpoints and this and that. So basically, every aspect of cancer cell advantage is being attacked by targeted therapy. So I'm going to talk about these broad groups and then give a few examples. So again, growth inhibitors, these are the pathways you can see in this diagrams, angiogenic inhibitors here, and then checkpoint inhibitors, antibodies that do bind on the antigen, just in a broad way. So these are the 3 groups of drugs that are more commonly used, and they have ophthalmic toxicity. Growth inhibitors, let's look at some of the examples. And there are many kinds of growth factors. We are familiar with VEGF, PDF, and fibroblastic growth factors, angiogenic, and there are many kinds of inhibitors of all these growth factors. So let me go back here. Here we go. Sorry. Can I have my, yeah, here it is. So there, again, tyrosine kinase inhibitors, I want to pay attention to that. Maybe hedgehog inhibitors, HDAC inhibitors. You hear these names, they're all basically inhibitors of growth. And then we have, I think I'm having a little problem here. How am I not getting my, and then we have angiogenic drugs that, there's 2 different mechanisms. This is Avastin, this is sunitinib, and thalidomide, and lenalidomide. They work slightly differently from each other, but basically they are inhibitors of angiogenesis. So again, that kind of group of drugs. And of course, you're familiar with these names, particularly with ipilimumab, and then we have nivolumab, and pembro, and others even hard to pronounce. I don't know how to say this one. Atezolizumab. I don't know why they get these kind of strange names. I don't know. Really, I was trying to kind of learn them, speak them, but I can't. But in any case, you get an idea that they belong to this broad group of drugs, and you can group them and then kind of study certain cancers, they're using this kind of drug, other cancers, they're using this group of drugs, and for some, they're using this kind of drugs. So different cancers, a certain group of drugs, just in a very broad perspective. And although these drugs are supposed to be targeted and specific, but they do overlap with some normal physiologic functions. So it's not that they're they're targeted for the cancer pathway, but they're not exclusive to only the cancer. There's an overlap to normal cells, and therefore you have this toxicity. So they're targeted in the mechanism, but they're not targeted in toxicity. I mean, you can have toxicity of normal cells there too. So, and strange enough, the ophthalmic complications are rather common. We don't have so many complications, say, with chemotherapy for every case, but here you're seeing a larger proportion. And I'm going to refer to a landmark paper by Dan Gombos, where you can go and read more about it, because that's what I did. And they're also emerging, so you kind of have to pay more attention as new drugs come along. Okay, here. So I think we have to focus this, and this is very relevant to us because they're ophthalmic oriented and they are emerging as new and more drugs are coming in the market. What's that happening here? Okay. And the other thing that's important for this, as compared to, say, chemotherapy or as compared to radiation, that some of them are immediate. This toxicity is immediate, and they are may affect the dose that the patient has to take, and many times they may be unrecognized. So, patient is having these drugs in a cancer hospital and says, "I have blurry vision," and nobody gives attention to blurry vision. They say, "Oh, your counts are good. You can walk, get into the wheelchair, and you go home." And so I think these drugs these complications are unrecognized. I mean, that's the truth. I work right in front of a cancer hospital. I know exactly what happens. This is what happens. Anyhow, so I would like to say that this is actually one of the very good articles on this topic. Dan Gombos is here in the audience, so if you have questions, you can ask him. Okay, and basically trying to get a handle on how common are these side effects, which drugs have more likely to cause toxicity, and if there's any kind of a specific profile. So he reviewed, at that time, FDA labels of 138 drugs, and about 20 of them had ophthalmic toxicity labeled in the FDA label. That doesn't mean they don't have toxicity. That's not been recognized before, but at least 20 out of 138. So you can see that's not that rare, and some had been unreported. And then they searched literature, etc., and found that it's not uncommon to have these complications. And again, this is blurry vision, unrecognized, okay? And we'll talk about some more of that. But fortunately, the serious complications like corneal melting, corneal ulceration, retinal changes, vascular occlusions of the retina are actually very uncommon. So they're fortunately rare, but there are other minor or let's say reversible complications are frequent. So let's go back to the different parts of the eye. Start from eyelid, orbit, anterior segment, retina, and optic nerve. And we wonder, why are we seeing so many ophthalmic complications of targeted therapy? Because the eye is a complete organ by itself, and so it has all components. And you see, particularly in the retina, you see all kind of mechanisms of cell signals, pathways, etc. And I think that's the reason. And the eyelids, etc., are just skin. Conjunctiva, cornea are related. So you can see that whole organ structures, whole body systems are present within the eye itself. So eyelids, you have a patient who said, "Oh, I have this lashes suddenly too big, and I can't wear my glasses anymore, and I have to trim them all the time." Didn't bother her too much, but I'll show a picture of that. And that typically goes along with the drugs that are epidermal growth factor in that category. The most common side effects, though, I think, is from imatinib, mostly causing periorbital edema. It's about 70% of cases that get this drug. So that's a very high amount of toxicity. Things like uveitis, iritis are seen with antibodies, like ipilimumab. We'll show some examples of that. And also you can see, for example, keratitis. You can see conjunctivitis, which is not serious, but could be bothersome to the patient, and of course dry eye in all of this. So there's a huge spectrum of toxicity. It's not just one thing, one drug. And in retina, particularly, which can certainly affect the patient's vision significantly, is CSR-like retinopathy. And this is a work done and published by Jasmine. She's also here in the audience. She published a series on it, and I'll show an example from there. And also you can get optic nerve changes with rituximab, which, as you know, is used for lymphomas. So again, look at all the organs. Just like for radiation, you pretty much can get every layer affected in some different mechanisms. So, and these are, I think, important because they are evolving and emerging. So let's look at some examples. Here's a lady I mentioned to you. This is our patient. Look at her lashes. I mean, I would say some people would pay a lot of money to get these big lashes. She got them for free. And not for free, when these drugs are not cheap, as you heard about that. So look at that. I thought it was like monstrous. Huh? Anyway, that's interesting. And here's another patient who kind of had this kind of a severe acne-like thing on the face, and then it faded away. It was very clear that he was just on epidermal growth factor drugs. Here's a patient from Dr. Jager's group, and they were kind enough to share the slide with me yesterday, presented with ocular rosacea, conjunctivitis, keratitis-like appearance. Again, the thing is that some of the oncologists really don't understand, and they just they ignore when the patient mentions anything to them. But if they kind of get a little bit more into detail, they will realize that these can be treated and there's something seriously going on. I think most important really is this uveitis that we see with these antibodies. Also with dabrafenib and trametinib, patient had metastatic skin melanoma. And it can be, blinding. This girl had 2100 vision in both eyes. She couldn't drive. She's supposed to get this chemotherapy, supposed to go to the hospital, supposed to go to appointments, but she can't get there because she can't see. So it can be a huge burden. So the moment we put her on steroids and got her vision back to normal, almost 2030, 2020, then she could drive to the hospital. So this is important. They may be dying, but as you know, they don't want to die and be blind before they die. So really, I think this toxicity is important from that perspective as well. And also at the same time, one could see that her lashes had become totally white. And again, we talk about vitiligo and those kind of inhibitions. So this is taking away all the melanocytes. So she had become blonde and not her eyebrow, but the other patients, and her lashes would become totally white. So again, this is a toxicity profile, not really that important, but certainly indicates that something is going on. And the way to manage her, in her particular case, they reduced the dosage of the drug, and we continue with steroids, etc., to take care of the uveitis. And here's the, I think, more significant toxicity that you might see with MEK inhibitors, which resembles CSR, but tends to be multifocal, tends to be bilateral, and need not necessarily be very identical. So this is more in the interdigitation zone. This is like a dome-shaped appearance. This is like a caterpillar and a wavy pattern. And this is just the splitting of the interdigitation zone. So it's slightly different from CSR, but it's CSR-like appearance. And patient may or may not have symptoms. If it's just involving the macula, then of course they'll have reduced vision, but otherwise they may not. And this may go away by itself, or may go away when you stop the drug, etc. So you have to be able to diagnose them, of course, suspect them, and we have ways, of course, to image them with OCT and photographs and angiograms, etc. But this, I think, so retinopathy is particularly important, and this is specific more with MEK inhibitors. So with epidermal growth factor related drugs, you see anterior segment complications. With antibodies, etc., you see more like uveitis-like appearance, and with MEK inhibitors, you see more like retinopathy. But there's an overlap, dryness, non-specific conjunctivitis, keratitis can happen. So coming back to targeted therapies, so they are designed for specific cancers, specific pathways, but certainly affect normal cells as well. And as I mentioned earlier, that ophthalmic toxicity is common and they're emerging. And so what we really need to do for them is to, as we see these patients, and the recommendations is to how to manage, is to do a baseline examination and then periodically examine the patients, pay attention to the symptoms, and then consider maybe reduction of dosage or discontinuation or supportive care like steroids on top of it. So that's the kind of guidelines, but it varies based upon the scenario or the response of the drug to the patient, other toxicities going on, and how much is the patient affected by it. And of course, for us, we just keep learning. That's the only way for us to keep up. And so therefore, thank you very much for inviting me to speak. And this is the way I reviewed myself, learned new things, and I hope I'm able to share some of that with you as well. Thank you.